Good morning, everybody. Today we're going to talk about dynamic contrast enhancement and its use in oncology. In particular, I'll be addressing the question of when is quantification essential. Here are my disclosures. Now we know that angiogenesis is a key step in the progression of cancer. Angiogenesis is incited by tumor hypoxia, and angiogenesis leads to hyperperfusion of tumors, which in turn leads to proliferative signals that eventually leads to tumor invasion and tumor dissemination. Angiogenic vessels are therefore critical for tumor growth and are driven by hypoxia. Neoangiogenic vessels are disorganized, irregular, and tortuous. I just thought I'd show you an example. So here is an example of a colonic cancer on an angiogram with a liver metastasis. What I'd like to do initially is to show you the organized structure of the normal colonic vessels. We can see normal venules and capillary networks all organized in a regular fashion. Here we can see the rather disorganized vessels that you would see within a colon cancer metastasis. You can see these rather irregular, tortuous vessels with flat venules. We can also see that the neoangiogenic vessels are found beyond the edge of the tumor in the surrounding stroma, explaining the blush that we often see on a contrast-enhanced CT around metastases. These structural abnormalities of the tumor vasculature forms the basis of the differential enhancement that we see on dynamic contrast-enhanced CT and MRI. We know that the angiogenesis promoters and formerly the suppressors were key anti-cancer targets, and the development of antivascular treatments has made angiogenesis imaging more important in assessing therapeutic efficacy, because we know that traditional anatomical imaging in terms of size criteria are unable to detect changes in tumor vasculature because anti-angiogenic drugs used by themselves are often cytostatic. Here is an example of a patient receiving pazopanib, an anti-angiogenic drug for renal carcinoma, and we can see decrease in vascularization of many of these liver metastases and of course of the primary tumor, both in the arterial and in the portal phases of contrast enhancement. You can see only minor reductions in tumor size, but a profound reduction in vascularization. The fact that size change is an inappropriate endpoint for anti-angiogenic drugs has been noted for a number of tumors. So for example, on the right hand side we can see the data on sorafenib, which led to the licensing of this drug. You can see an improved overall survival and improvement in time to progression, but if you look at size changes and responses, you can see that they are almost identical. It was always thought that time to progression, this variable here, would be the surrogate of activity for cytostatic drugs because it reflects stability of disease. However, for some anti-angiogenic drug combinations, progression endpoints such as delays in time to progression did not lead to overall survival, particularly for breast, prostate, and glioblastoma, as a result of which anti-angiogenic drugs are not licensed for these indications. The bottom line is that we need better methods, better biomarkers to predict who is going to benefit in terms of symptom control and in survival, and also to predict who is likely to experience harm. Now, there are many ways of imaging the vasculature and I've just outlined those over here. Today we're really going to talk about the first two rows, the dynamic contrast enhanced MRI and dynamic susceptibility weighted MRI. Let's just start off by showing you how the experimental setup alters what is imageable at any given time. So here is a large pelvic mass. You can see it's solid. If we do a susceptibility T2 star sequence, we can see darkening of the tumor, particularly if you acquire images once every couple of seconds for 1 to 2 minutes. This darkening is quite classical, whereas if we perform a T1 experiment, which is slower, we can see this enhancement. And the different patterns that one observes, positive or negative, is very much dependent on the experimental setup. So if we were to look at the darkening experiment first, and here is part of that first pass effect of the contrast agent going through the tumor vasculature, you can see the ROI shows a decrease during the first passage and then a recirculation phase. That is caused by the presence of concentrated contrast medium within the vascular space, lowering the signal intensity. Software for this is available in academic centers, so it's possible to fit a gamma variant fit and derive measures on a pixel by pixel basis on the relative blood volume, relative blood flow, and the transit time, and you can see how these are simply related by this equation. Now, the only software that's available commercially for clinical use exists in the brain, and similarly you will have seen these types of images in the brain, relative blood flow, relative blood volume maps. So let's talk about the T1 experiment. The T1 experiment, as we said, reflects the delivery of the contrast medium to the vascular space and then the leakage of the contrast agent into the extracellular space, where the dilute contrast causes this enhancement in the time signal intensity curves that you're able to see. Now, if you superimpose the T2 star experiment on the T1 experiment in time, you will notice something really quite interesting. You'll notice, for example, in this pixel, which is taken from here, that the upslope of the DCE experiments coincides with the downslope of the DSC experiment. In the center here, you can see no enhancement, and you see no decrease in the T2 star experiment. Similarly, at the edge here, anteriorly at the front where it is hypervascular, you can see how the decrease in signal intensity here on the T2 star experiment coincides with this increase here on the T1 experiment over time. So, in other words, the kick that you see initially on a T1 weighted DCE is in fact related to blood flow, because we know the DSC experiment is sensitive to blood flow and blood volume. The equilibrium phase occurs when the flow into the extracellular space occurs at the same rate as the rate at which the contrast agent goes from the extracellular space into the vascular space, and the washout phase occurs because there is less delivery to the extracellular space and a lot more of the contrast agent is washing out towards the end of the experiment, leading to this washout. Now, there are a number of ways of evaluating DCE scans. The easiest way is to use morphologic descriptors of the enhancement on fat suppressed or subtraction images. Another way to look at it is to look at the time signal intensity curves by themselves. and you can do this qualitatively via a shape analysis. You can do it semi-quantitatively, or you can do full quantification using pharmacokinetic modeling. Clinically deployed systems often use combinations of these ways of analysis. So let me show you an example of morphologic descriptors that can be used for prostate cancer in the peripheral zone. So here are examples of diffuse, enhancement, low grade in the peripheral zone of the prostate gland, which would be classified as a score 1, highly unlikely to represent clinically significant disease. This would be classified as a score 2, and we can see that there is brisk but early enhancement, but this is either linear, patchy, bilateral, and symmetric. So those are the kind of descriptors one would use to assign a lower probability of cancer. Here are examples of rather more aggressive features, such as a score of 4 would be assigned to an area of brisk early focal but homogeneous enhancement with no mass effect or invasive features, and the highest likelihood of cancer would be assigned to a lesion that was a mass, that was heterogeneous, asymmetric, showing invasive features such as extracapsular disease or seminal vesicle enhancement. The PI-RADS version 2 uses morphological descriptors, but only scores it as positive or negative. And that down rating of the DCE assessment reflects the lower incremental value of DCE features when compared to diffusion imaging and T2 imaging for lesion detection. And this is a type of lesion that will be classified as positive. In a patient with prostate cancer, we can see that we are able to pull out on a dynamic enhanced study the presence of a lesion not easily depicted on the T2 scan, but we can clearly see it on the DCE-MRI images. So this would be positive in the new PI-RADS version 2 system. Now, morphologic enhancement patterns such as these have also been described in the breast, and we know that these types of patterns are in fact biologically meaningful. If you take an early subtraction image and a late subtraction image and you subtract the two subtractions, you would get this sort of image. This represents what enhances late in a dynamic contrast enhanced study. Now, if you look at these images and you histologically verify what's happening, this early enhancement that you see represents areas of high microvessel density counts. There tends to be elevated expression of VEGF, tumor infiltration at high levels along the margins. The delayed peripheral enhancement one can see around tumors represents areas of inflammatory infiltrate and fibrosis, and the delayed enhancement that you see in the center of the tumors tends to represent internal fibrosis and necrosis. So you can see that these morphological patterns do have biologic meaning. In the clinic, of course, we use both morphology and signal enhancement to make diagnoses. So if you see a well-defined, homogeneous, enhancing mass lesion where there is a type 2 curve, but all the curves superimpose upon each other, that clearly is benign, and in this particular case it would represent a fibroadenoma. This superficially looks the same, but you can see there is internal heterogeneity. You've got a type 3 curve, and this is clearly a different type of mass lesion with irregular margins. This is an invasive ductal cancer. You can go beyond morphology you can start to look at the curve shapes. You can extract physiological indices from the curves, and this can either be done using pharmacokinetic modeling or model-free indices from one or more parts of the enhancement curve can be obtained. There are several curve shape classifiers available in the literature. I've just put out some of them over here. The most common one is this one over here, used by Kuhl in 1999, although we also use these descriptors here by Daniel in Radiology of 1998. So here is an example of using DCE-MRI together with a curve shape to find a recurrence in a patient with prostate cancer. You can see this is the recurrence in the prostatectomy bed. You can see this area is hypercellular on the diffusion sequences. It is also hypervascular and is not visible on the PET scan, as you might imagine, due to the adjacent accumulation of glucose within the bladder just above the bladder urethral anastomosis. Curve shapes we know correlate with the pathology in the breast, and a type 3 curve is much more likely to represent a malignant lesion, whereas a type 1 curve is much more likely to represent a benign lesion. PI-RADS version 1 in fact combined both morphology as well as curve shapes to assign the likelihood of a clinically significant lesion based on the curve shapes. And here is some validation of some data that emerged in 2012, and we can see with a PI-RADS score of 1, there is almost a negligible chance of having a positive core for clinically significant disease. Similarly, for if you had a score of 3, you only had about a 15% chance of having a clinically significant tumor. However, if you had a score of 4 or if you had a score of 5, you can see that the probability of having a positive core from those areas was increased. So in other words, the combination in the prostate gland of a morphological assessment with a curve shape was able to predict the percentage positivity of cores from a particular area or lesion. We used a 5-point curve shape to look at disease-free survival and overall survival in 58 women before and after 2 cycles of neoadjuvant chemotherapy. And here's the classifier that we use, which I pointed out to you earlier. You can see that overall survival correlated with changes in curve shape after 2 cycles of neoadjuvant chemotherapy. So if you went from a curve shape of 5 to a 3, or from a 4 to a 2, or a 3 to a 1, then your survival was much likely to be better than if you had a curve shape of less than that. So if you just went from a 5 to a 4, or from a 4 to a 3, then you are much less likely to get benefit in terms of survival from neoadjuvant chemotherapy for locally advanced breast cancer. Okay, so let's continue with indices that you can obtain from time signal intensity enhancement curves. It's possible to obtain physiological indices using pharmacokinetic modeling of the concentration changes in and there are a number of models that can be used. The extended TOFS is probably the most common, but there are others. The shutter speed model seems to be quite popular nowadays. Or it's possible to use model-free indices that describe one or more parts of enhancement curves. If you were to apply a model, then it's possible to obtain kinetic parameters such as the transfer constant or the wash-in rate. The wash-in rate represents the rate of exchange of the contrast agent from the vascular space to the extra vascular space. So it's this transfer constant. But it's also possible to obtain an idea of the leakage space and the rate at which the contrast agent returns to the vascular space, so-called washout rate, or KEP. But it's also possible, depending on the model, to obtain a fractional blood volume, or even an area under the curve in the first 60 seconds. So these are quite commonly obtainable parameters from modern software. Now, we would expect the curve shapes to correlate strongly with transfer constant, the wash-in rate, and it does. So here are a whole bunch of patients that we looked at, and you can see that as your curve shapes change from 1 to 5, so that also correlates very strongly with increases in transfer constant, which is what we would expect. So what does the transfer constant actually mean? When one looks at review articles, you notice that the Ktrans meaning changes according to the flow and the leakiness of the underlying vasculature in a particular tissue, which means that Ktrans can change by anatomical location and the therapy status of a particular tissue. So if you have a low permeability situation like this, for example, where most of the contrast stays within the vascular space, and this classically occurs in the brain, then the transfer constant, the rate at which the contrast agent goes into the extracellular space, is a reflection of the permeability surface area product. In tumors, you often find this to be the situation, where you have high permeability and a high leakage of the contrast agent during the first pass. In this particular instance, because a lot of the contrast agent ends up in the extracellular space, the transfer constant represents the blood plasma flow per unit volume of tissue. And this is what we see most commonly in tumors. So the biological meaning of Ktrans can vary by anatomical location. So if you look at this patient with a Gleason 6 tumor on the right hand side in the transition zone, and we see this green curve, there's a wash in and wash out, and here the transfer constant is reflecting the plasma flow per unit volume of tissue. On the left hand side here, we've got wash in and then a plateau. In this particular case, the transfer constant is reflecting the permeability surface area product. So the biological meaning of Ktrans on the right and on the left side of the gland are different. Similarly, if you look at this patient with prostate cancer who's being treated with an LH-RH antagonist, which is an anti-androgen, we can see that the transfer constant decreases with treatment, and the curve shapes go from wash in, wash out to a more plateau type appearance. So before treatment, we are looking at the transfer constant, meaning the blood plasma flow, whereas after treatment, you can see that the transfer constant reflects permeability and less perfusion. And this change meaning of the transfer constant, depending on the biological tissue and on the treatment status, is something that has been noted by many. Not only that, but the value of Ktrans changes according to the complexity of the model. The value changes according to the complexity of the model. So if you were to add a vascular component to the model, that automatically lowers Ktrans values. So here is a patient with the breast cancer, the same tumor with two different models. Here is a model that does not have a vascular function, and this model here has a vascular function, which is indicated by this peak. Now, what I'd like you to do is to look at the value of the Ktrans. The scale is exactly the same. You can see how just by adding a vascular volume, the Ktrans value changes. So Ktrans values changes according to the complexity of the model used for the fitting the observed data. So that's an important thing to remember. The other thing you need to remember is that the Ktrans meaning and value change according to the input function that is used to model the enhancement curve in high leakage environments like tumors. Many of you will ask, what is the arterial input function? Now, what you have to remember is that this is what we observe at a tissue level. Signal intensity, which is then modeled, and we are interested in extracting these values: the transfer constant, the rate at which the contrast agent returns to the blood plasma, the plasma volume, and the extracellular space. We can't do this unless we know what the rate of delivery of contrast agent is to the tissues, and this is the arterial input function. There are several ways of obtaining an input function for modeling of DCE data. It is not possible to obtain measurements at the level of the tumor in most clinical studies. Mostly what you find in the literature and within software implementation is a population averaged or a pool input function, and they go by various names such as the Weinmann function, Fritz-Hansen function, the modified Fritz-Hansen function, and the Parker recirculation. Now, the first three, the Weinmann, the Fritz-Hansen, and the modified Fritz-Hansen, are examples of what are called bi-exponential waveforms, or you can have a more complex waveform such as the Parker recirculation. Now, the important thing to remember is that the maximal amplitude changes according to the input function that is being used. So in the Parker function, you can see you have a much higher amplitude compared to the Weinmann function, where the maximum concentration is about 1 millimolar. The choice of the AIF on curve fitting is important. So here, for example, is the same patient that we saw previously with the two different curves. If you use the Weinmann function, you can see that their fitting is not so good. The modified Fritz-Hansen gives you a good fit. The Parker recirculation function gives you the best fit. On the left-hand side, with this different shaped curve, we can see the Weinmann function is not bad. The modified Fritz-Hansen does very well, and the Parker recirculation gives a reasonable fit. But what you have to realize is that the values of the Ktrans change according to the choice of the input function. So here you can see the transfer constant has a value of 3.2, and here for the same curve but a different input function you have a value of 0.21. So there's an order of magnitude difference, and again you can see even with this other curve shape, you can see that this is 0.39, whereas the Parker recirculation gives you a value point of 0.01. Now, which is the best one to use? Which is the best model? Which is the best input function to use? Well, we recently looked at this, looked at 27 women who had locally advanced breast cancer and just fitted something called the standard Tufts model. And what we noticed was that the most realistic values for leakage space were for the cosine plasma model, for the Parker recirculation, and for the modified Fritz-Hansen. For the others, you can see much higher values of leakage space than you would find physiologically. Certainly, you would not find 60% extracellular space in a tumor, which is what the femoral artery function would predict. So what is the best input function to use for DCE-MRI? And how reliable are the kinetic parameters? Well, if you have a really fast acquisition with less than 5 seconds of time resolution, you could use one of a number of different functions, pooled or individual AIFs, and the reliability of Ktrans, leakage space, KEP, and VP would be very good. If you had a data acquisition that was between 5 and 15 or 20 seconds, then you should not use an individualized AIF. You're probably better to stick to a pooled bi-exponential AIF such as the modified Fritz-Hansen approach, and that would give you reasonable reliability of Ktrans, leakage space, as well as the washout or KEP. And if you were using greater than 20-second resolution, we would not recommend you do pharmacokinetic modeling. If you are going to do it, then use a bi-exponential Weinmann function or a Fritz-Hansen function, and the only reliable parameter you are likely to get is the washout rate. So you need to match AIF choice to the temporal resolution of the scan. So I can see that many of you are now losing the will to live. I can convince you that quantification can be useful, but it just seems too complex. Is there something between curved shapes which seems too simple and full kinetic modeling that could be useful in the clinic? Well, you can extract model-free indices from time enhancement curves, and I just wanted to touch on these very briefly. If you see a curved shape, it is possible to obtain various indices such as the onset of enhancement, the initial gradient of enhancement, the maximal enhancement, the maximum time intensity ratio, which is a ratio between how much it enhances and how long it takes to get to that point. Or you can get something called the area under the gadolinium curve, which represents this particular area. The area under the gadolinium curve seems to be quite interesting. If you look at these two curve shapes, you can see that their area is in fact identical, but the transfer constant would be quite different. If you have a high wash in, high wash out, that's a high transfer constant. If you just have wash in, that would represent low transfer constant. If you were to take just the initial area under these curves, then this initial areas under the curve should reflect the transfer constant and therefore should be related to blood flow. And you know, it turns out that it is. So here are correlations between the initial area under the gadolinium curve at 60 seconds and the transfer constant. You can see a good relationship. In prostate cancer, you see a good relationship. In ovarian cancer, and here is the initial area under the gadolinium curve with the blood flow and the blood volume for the same tumors. But these relationships are complex and do not apply to all lesions. So what do you get by undertaking such complex analyses? The disadvantages are obvious. The data analysis is more complex. There is confusion about the biological meanings of the kinetic parameters we obtain, and there seem to be so many models. And if we choose the most simple models, it may not fit the data that we observe. The advantages are that we can obtain biologically relevant physiological parameters, and because we are independent of scanners and manufacturers, we can then exchange our data with other people's data in different centers. So those are worth having. So when do you absolutely need quantitative MRI? Well, I would say that when you are performing a validation study, when you're establishing the usefulness of DCE-MRI in a specific clinical area, then you initially need to start off using quantitative techniques. Quantitative techniques are also very valuable when you use it for drug development, particularly in phase 1 pharmacodynamic studies. Let me show you an example of a validation experiment. I was interested in knowing how well dynamic MRI was at predicting pathological outcomes in patients with locally advanced breast cancer after 2 cycles of chemotherapy. Here are 2 examples of a patient who is responding and not responding. So in this example, you can see that these lesions get smaller on morphology, they reduce in the transfer constant, and the relative blood flow also reduces, whereas in this example, this patient was not responding. You see no change in morphology and no change in transfer constant. How well do these parameters behave in a number of different patients? We did this for about 50 patients and looked at the value of morphology and transfer constant in being able to predict for pathological response, and what we found was that transfer constant was much better than size in terms of sensitivity and specificity, but there were a number of other biomarkers such as relative blood flow, relative blood volume changes, as well as KEP that were also efficacious. So here is an example of using quantitative variables to predict pathological response in neoadjuvant chemotherapy. Now, we also found that changes in transfer constant were also able to predict overall survival in these patients. So this is a different type of validation experiment. Here we can see patients who have large changes in transfer constant live longer. People who have smaller changes in transfer constant live less long. But the data I've already shown you shows that the same thing is true just by looking at changes in curve shape, and we also demonstrated this previously. Now let me show you an example of a phase 1 clinical trial that incorporated DCE-MRI as a pharmacodynamic biomarker. So phase 1 clinical trials are trials that are undertaken when the drug is first given to man, and the question that is being asked is there a hint of biological activity? And that's when you require pharmacodynamic endpoints, and DCE-MRI is one of these pharmacodynamic endpoints. So here, for example, is a patient from a phase 1 clinical trial where we were treating with an anti-vascular treatment, and here is the transfer constant obtained on 2 occasions before the drug was given, and this is the transfer constant given 4 hours afterwards, and you can see a dramatic change in the transfer constant in individual lesions, particularly within the center of the lesions, compared to before treatment, and that represents a drug effect. So that kind of data can then be put into what are called dose-finding studies. So here is a patient who is receiving the same drug, and you can see we've used 3 doses, and with increasing doses, again at that 4-hour time point, we see marked reductions, stepwise reductions in transfer constant, which then reverse by 24 hours. So this is a nice example of the use of quantitative DCE-MRI for pharmacodynamic assessments. Quantitative imaging can also be used as part of quantitative multiparametric imaging assessments. For example, if you want to do radiomics, or you want to look at integrating these biomarkers with other biomarkers that you've obtained. So let me just show you an example of its value. So here is a patient receiving Avastin, an anti-angiogenic drug, in the setting of GBM. Now, if you looked at this patient, you can see an initial reduction in the amount of enhancement and then tumor growth. So you would say this drug doesn't work. And you'd be correct, because on the T2 you observe the same phenomenon, a reduction and then a growth of the tumor. Clearly there is no effect on the tumor. However, if you looked at the transfer constant, which is, remember, represents the leakiness of vessels, what you observe was that there is a reduction in transfer constant that is in fact maintained. So the drug does work. The drug is meant to reduce vascularization, and in fact we can show quite convincingly that there is reductions, sustained reductions in the vascular permeability. What seems to increase and accounts for this enhancement that you observe is in fact the vascular volume. You can see how the vascular volume increases over time. So this is an example of what's called vascular maturation as a result of anti-angiogenic drugs. So this is the information that would say, yes, the drug works, it has an anti-permeability effect. Yes, the drug works because it causes vascular maturation. No, the drug doesn't work because the tumor continues to grow, and that's why this drug has never been licensed for use in GBM on its own. So how do you introduce quantitative perfusion imaging into the clinic? Well, in the validation phase, you should use quantification. In the clinical deployment phase, you can move to qualitative and semi-quantitative methods. So in the clinic, use curve shapes, use scoring systems, use structured reporting. And here's an example of how multi-parametric MRI, which includes DCE-MRI, used DCE into clinical practice. So you can see that multi-parametric MRI, which includes DCE-MRI, was validated in a number of studies, including quantitative studies, but when it was deployed into clinical practice in 2011 as the PI-RADS version 1 system, in fact there was just curve shapes. And in fact the latest version, which is PI-RADS version 2, which came out in 2015, only uses descriptive analysis alone. So you can see how we went from the clinical validation, which included studies that were quantitative, but when we deployed the technique we went down and we started using curve shapes and finally morphological descriptors alone. So should you use DCE-MRI in the clinic? It should be used in clinical practice, and you shouldn't really be put off by the complexities of the technique, some of which I was able to illustrate to you today. Complex quantification has roles in validation, in drug development, and is needed for multi-parametric assessments, which is what we've just talked about. I think in the future we should be thinking about using quantitative perfusion as part of a quantitative multi-parametric assessments. This is to improve our understanding of tumor heterogeneity, including response in the era of targeted and high precision medicine. Thank you very much for listening. I hope this talk has been useful.